Good evening, everybody. My name is Dr. Matthew Holder, and I am the President-elect of the American Academy of Developmental Medicine and Dentistry, and I'm your host tonight for the Physician Education in Developmental Disabilities webinar series, presented in partnership with the Florida Center for Inclusive Communities and sponsored by the United States Department of Health and Human Services Administration on Intellectual and Developmental Disabilities and the Florida Developmental Disabilities Council, Incorporated. Tonight is the 7th installment of our 12-part series, occurring every Tuesday night at 6 p.m. Eastern Time through October 9th. Each of the 12 parts of this series is accredited by the American Academy of Family Physicians for 1 credit hour of AAFP prescribed credit. This is recognized by the AMA as equivalent to 1 hour of AMA Category 1 credit. Archives of each presentation are available about 1 week after the live event at www.aadmd.org. The archives are accredited for CME credit for the next 2 years. At the end of the webinar tonight, we will give you more information about how to obtain your CME certificate. For those of you who are not physicians, you may also use this link to obtain a certificate of completion. Just keep in mind that we are only able to award continuing medical education credit for this webinar series. As always, at the end of the presentation tonight, there will be some time for questions. So if you have any questions, please type them in the question box of your control panel as you think of them. We will try to get through as many questions as possible during the time we have left. So tonight marks the beginning of the second half of our 12-part series. The first half of the series was focused on more general and more foundational topics. We talked about things like history and terminology, some basic science discussions, talked about communication, self-determination, informed consent, the patient's circle of support, and we concluded with some general considerations about assembling accurate clinical information. The second half of this series now will focus on more specific topics. So we're going to be talking about things like optimizing well-being, transitioning from pediatric to adult care, behavioral medication management, improving practice quality, and financial considerations. But in order to kick off the second half of this series, we're going to continue our 2-part presentation from last week on assembling accurate clinical information and look at more specific considerations and special considerations. So joining us again tonight is Dr. Linda Edwards. Dr. Edwards is currently an Associate Professor of Medicine and Chief of the Division of General Internal Medicine in the Department of Medicine at the University of Florida College of Medicine at Jacksonville. She also serves as the Associate Chair for the Department of Medicine. She completed her internal medicine training at the Jacksonville Health Education Program in Jacksonville in 1984. She has been a member of the Division of General Internal Medicine since 1985 and has become Division Chief in 1998. In 2008, she also served on an NIH consensus panel that reviewed the use of hydroxyurea in the treatment of adults patients with sickle cell disease. Dr. Edwards' clinical interests include healthcare transition for youth with special healthcare needs. She is the co-medical director with Dr. David Wood at the a UF pediatrician of JAXHATS, otherwise known as the Jacksonville Health and Transition Services Unit. JAXHATS is a primary care medical home for youth with special healthcare needs. So at this time, I would like to turn the presentation over to Dr. Edwards. Dr. Edwards, can you hear me?
I can. Thank you, Dr. Holder.
Thank you.
And good evening, everyone. For those of you who were with us last week, we were anticipating possible some hurricane-type weather, but that has passed, and now I understand Dr. Holder's area of the country is experiencing some of the residual of that, so I hope everyone is safe. Today, or last week, we spent a fair amount of time talking about how to gather data from various sources, including the patient or when unable to get information from their caregiver. And we looked at some specific syndromes and what we as primary care physicians should be focusing on when evaluating the adult with developmental disability. So today we're going to look at some of the specific conditions that need to be addressed in this population. And as I shared with the group at our meeting last week. My experience with adults with developmental disabilities has come through working with Dr. Wood in Jack's Hats, which is a transition clinic for young adults between the ages of 16 and 26 who have chronic health care conditions. And of course, many of these young people have developmental disabilities, and so my experience has been on the job training and what I have learned from Dr. Wood and his expertise in helping me learn to navigate the care of this patient population. And I would like to review the goals with you tonight that we will be covering. We covered several goals last week, but this week we're going to talk about the annual health and function assessments, and that would include oral health assessments as well as special high-risk conditions and comorbidities that may occur with certain developmental disabilities. We're going to talk about what secondary health conditions may develop in this patient population and what to do to identify them. We're going to talk briefly about psychiatric conditions and how to provide appropriate treatment and referrals for this patient population as well. And in addition, we're going to talk about oral health screening and prevention, and I'm actually going to spend a little bit of time on that because it is such a big issue, and also talk about developing individual health plans for adults with developmental disabilities so that they can be monitored appropriately. And then we'll talk about issues concerning sexual and reproductive health in this patient population as well. Now, this slide was shown last week, and I'm not going to review this. We were talking about barriers to access for adults with developmental disability. But I think what I want to emphasize is that when we as primary care physicians see patients with developmental disabilities, it can seem somewhat overwhelming when trying to address the multitude of issues that may need to be addressed. And so I think that what we have done in our practice is we have initial visits, as we talked about last week, and acute care visits for acute issues, but then we also have annual visits, wellness visits, preventive care visits, however you would like to couch that, and chronic care visits. And I think that if you schedule patients for specific visit types, this is helpful for us as clinicians to manage our time when seeing these patients, and it also helps the patient to know what their expectations will be for that visit. And so these are important types of visits, and this would help us identify what screening we might need to be anticipating and what we would incorporate into the annual visit or the wellness visit. And so, again, one of the barriers to access is just seemingly the overwhelming needs of some of these patients, and if we can carve them out a little bit better, it is easier for us to manage them. So we'll talk about that further today. And also, again, I used this slide last week, and I wanted to just remind everyone that we have this healthy survivor effect, and we know that the more severely disabled individual with developmental disability may die younger, and therefore the healthier individuals live longer, but if they are living longer, they have a greater likelihood to make poor lifestyle choices. And we know that lifestyle choices do indeed impact ill health, and nutrition, exercise, and medications are critical for us to evaluate when we're seeing these patients, again, whether it be an annual visit, a chronic care visit, or a wellness visit. And so, I just wanted to reiterate that it is important to remember that while these individuals have a developmental disability, they indeed may be making choices that are going to impact their life negatively and their health negatively. So getting started, again, we want to remember that when we are seeing this group of patients in our office, that there are certain things that we want to make sure we include in our evaluation of them, as I mentioned at our last presentation, we want to make sure that we do the usual review of systems for this patient population, but then we also want to make sure that we are inquiring about conditions that we know have an increased prevalence in certain disease states, such as dementia or thyroid disease and Down syndrome. We also want to make sure that we're inquiring about level of physical activity, as it may impact not only the development of type 2 diabetes, but may also impact joint and pain, and these are musculoskeletal issues, and these are very important in certain patient populations. And so again, we want to inquire about the physical activity for those who are able to be physically active. And then it is important to address nutrition for similar reasons. And I think all of us are aware of the difficulty with good nutrition in this day and age, and the expense that can come with eating well. But nonetheless, we want to review this with the patients and their caregivers as appropriate. In addition, there are some other areas that we'll want to highlight when doing a review of systems in this patient population. And again, remember that the adult with developmental disabilities may have a greater likelihood of developing a seizure, or may develop additional seizure types. And so it is important to inquire about tics, to inquire about falls, things that are not usual movements of the patient that may be a clue that a new seizure type has developed in a patient. We also want to inquire about changes in vision, as cataracts may develop, and they may develop rapidly, and this can be seen in Down syndrome and other patient populations as well. Interestingly enough, hearing can be impacted significantly. We don't always think about that in the younger adult, but in the young adult with developmental disability, we need to know that the external auditory canal may at times be narrowed, and they may have had recurrent otitis infections that can lead to hearing loss. And so it is important to inquire about that, as well as inquire about whether they have had problems with cerumen in the past. Another review of systems would be, are there any issues of oropharyngeal dysphagia? Is there coughing that occurs after that patients eat, for those that do swallow, or even if they have gastrostomy tubes, are there any issues with regurgitation or difficulty in maintaining secretions? And then the dental issues, as I said, that we're going to talk about in more detail in just a few moments. So these are some of the systems that we want to focus our attention on, and then certainly there may be components of a disease entity that warrant other questions. Again, knowing more about a presentation of an adult with developmental disability can help direct you with regard to questions and screening that may be warranted. And lastly, we have sleep issues, and again, snoring may be an indication of sleep apnea. Insomnia may be a presentation of a medication effect, severe GERD, a number of issues that need to be looked at with regard to sleep issues. And many times the caregiver will be able to clue in right away as to what they think the concerns might be. Issues of incontinence, issues of change in cognition, and again, cancer screening. And so we're going to look at all of these in a little more detail, but these are some of the systems that we'll want to focus our attention on when we are evaluating these adults in our practice. Now, last week I had reviewed with you some general guidelines from the Canadian Consensus Guidelines, and there are actually more specific guidelines with regard to physical health and behavioral health. And actually, I was a question was raised by someone who had looked at the presentation questioning if there were guidelines other than the Canadian guidelines. I was not aware of them. Dr. Holder and the American Association of Intellectual and Developmental Disabilities, as well as the American Academy of Developmental Medicine and Dentistry, and others have spent a great deal of time developing a set of guidelines for the U.S. to be used, but these have not yet been published. And so what we have are the Canadian consensus guidelines, and I'm going to review those with you. I've taken the liberty to condense the guidelines to some bullet points, but I would encourage you to review the detailed guidelines that are presented in the paper that's referenced in the bibliography. And again, I would anticipate that many of you would not, or any of you would find these guidelines surprising or not warranted. Physical inactivity and obesity are common in the adult with developmental disability. Vision and hearing impairments are underdiagnosed. And again, we're going to talk about screening, and at the age of 45, if no symptoms, individuals with developmental disability should have both ophthalmologic as well as hearing testing at least screened for, and then further testing as warranted. Dental disease is one of the most common health problems that we see in the adult with developmental disability, and we will discuss that further. And then remember that cardiac abnormalities are prevalent. Additional physical health guidelines from these consensus guidelines are that respiratory disorders such as aspiration pneumonia are common. Again, related to neuromuscular disease, oropharyngeal dysphagia, difficulty with maintaining their airway, medications such as anticholinergics that are used for other medical issues can contribute to this. And respiratory disease, particularly aspiration pneumonia, is a common cause of death in this patient population. And then we're going to talk about gastrointestinal and feeding problems. Interestingly enough, H. pylori infection in group home folks should be considered, and then screening for hepatitis A and hepatitis B. And lastly, no, I'm sorry, we've got a couple more to go here. We have, with regard to Canadian consensus guidelines, sexuality should be addressed with the adult with developmental disability, from discussing fertility issues to the issues of hypogonadism in men and gonadal dysfunction. Also, issues of musculoskeletal disorders are prevalent, from scoliosis to contractures and spasticity, as well as osteoporosis, related to a multitude of factors that can contribute to bone health. I also we're going to talk a little bit about epilepsy and how it should be managed and what we should be looking for in the patient with epilepsy. And then we find in this patient population that there is a higher incidence of thyroid disease and gonadal dysfunction, and then because of the adult with DD being less likely to be active and choosing less healthy diets and lifestyle, there is the issue of diabetes in this patient population as well. And then cancer screening. And these, I think, are very interesting and important for us as primary care physicians to remember. We're going to talk about gastroesophageal reflux disease, and there's a higher incidence of GI tract malignancies in this patient population. We see minimal cervical cancer in this patient population, and interestingly enough, although the incidence of breast cancer is not higher in this patient population, we see more cancer deaths, and likely related to screening or the absence of screening, and maybe limited family history in this patient population. Now, the behavioral and mental health guidelines, I think, are fairly straightforward, but important for us to remember. And again, discerning a behavior that might be related to an underlying disease or syndrome from a true psychiatric illness, as you might imagine, can be very difficult. So obviously it's important to involve psychiatrists and behavioral therapists early on, and it's critical in the management of these patients. And in our practice in Jack's Hats, it's not uncommon for us to see a young adult who carries the diagnosis of bipolar disorder, borderline personality disorder, ADD, ADHD, when indeed their underlying behavior may not be a true psychiatric disorder, but may be from their underlying disease and their inability to effectively communicate this to us. And then they're on a multitude of antipsychotics, which may or may not be appropriate for the management of their behavior. And so again, the consensus guidelines from Canada are very specific about use of psychotropic meds and antipsychotic meds being used only when there's a sound diagnosis and not for symptoms or for behavior management. Certainly, there are problem behaviors in this patient population with aggression and self-injury. Behavioral modification is more appropriate than to try and medicate the patients. So intervention seems to be more appropriate than medication. And certainly when agitation or aggression seems to be increased, we need to make sure that we are not dealing with an underlying medical issue that is going unaddressed. And then in many instances, just on the reverse of what I was talking about, of how differentiating behavior from an underlying disease to a true psychiatric illness, sometimes the signs of a psychiatric illness may be regarded as part of the developmental disability and therefore go undiagnosed and untreated. And there's a term called diagnostic overshadowing that you'll read about in the literature with respect to this. So we're going to talk about wellness and preventive care visits. We're going to briefly review these items here. As I said, we're going to spend some time talking about oral and dental health, talking about medication review, which is obviously critical in this patient population to ensure that the medications that the patient is on are appropriate for the management of their diseases, and that where possible medications can be discontinued. A significant amount of GI disease is seen in this patient population. We're going to talk about that. Bone health is important to manage in this patient population. Sexual health as well in the adult with DD, from managing decisions about fertility to gonadal dysfunction. And so it is important that we are aware of these things and are addressing them. Talk about epilepsy, the psychiatric issues, and then very briefly just the importance of health promotion and speaking with the adult with DD at a level they can understand, which is not always easy, but to help them understand the importance of screening for disease and for managing their health, and again involving their caregivers as well. So let's talk a little bit about oral health and its importance. I think that we would all anticipate that even for those of us who are healthy, who have insurance but may not have dental insurance, dental care is difficult to access at times, again, because of the expense. And so even our patients who do not have developmental disability do not necessarily receive the oral health care that they need. Certainly inadequate dental hygiene can lead to increased morbidity, and it can also lead to behavioral issues. I saw a young man with spastic quadriplegia this morning for the first time. He's in his mid-20s, and I spoke with his parents about regular dental care, and their issues were no, they did not take their son. They did their best to care for his teeth, but because of the spasticity associated with his cerebral palsy, it was difficult for them to clean his teeth, and they were concerned about general anesthesia for their son to receive dental cleanings, and then the access here in Jacksonville for dentists who provide oral care under general anesthesia is very limited. On exam, he has a history of bruxism, and on exam there was evidence that he was grinding his teeth, and he had some posterior enamel erosion that was evident on physical exam. So again, oral health is a big issue. 50% of patients with developmental disability will lack access to adequate dental care. and about 75% of them are relying on federal funding for dental services, and in Jacksonville the number of dentists that will accept Medicaid are very limited. We do have great colleagues in Gainesville who do provide dental care using general anesthesia to a number of our patients, and so we're very fortunate to have them available to us and our patients. And then it's interesting, patients who have developmental disability who live in an institution are likely to receive better oral care than the adult with DD who is out in the community. Their oral care may not be as good because of the supervised daily oral care that you see in institutions. And then we touched on this last week with regard to primary care physicians. There are funding issues, and there are few dentists who actually provide oral care using general anesthesia. And again, we've touched on many of these as we are going through this information. So socioeconomic status, the adult with DD's limited mobility impact their ability to receive adequate oral care. And then there is really not a very aggressive oral disease prevention, either by we primary care physicians in encouraging our patients and their caregivers to pursue more aggressive preventive care. And again, the inadequate training of some of the caregivers, and there's just not an emphasis on oral and dental hygiene. Barriers, again, I think we've already touched on most of these. Again, access probably is the biggest issue, whether it be lack of trained personnel or lack of recognition of the importance of oral health, but also then the difficulty in physical access to actually get a patient into a dentist office for oral care. In addition, this is a very diverse patient population, as you know, and spasticity may make the exam difficult, and so movement disorders may contribute to a poor exam. Chronic mental health issues with delusions and or hallucinations may make it difficult for the adult with DD to actually participate in the exam, and we need to remember that we are working with chronological aged adults, but they have the functional capacity of a child, and so they're fearful of the dentist. And then there are significant and debilitating medical conditions. We talked about autism last week, and patients with autism will have an aversion to touch in some instances, and so when the circumstances that they are being seen may make it difficult for them to be able to cooperate. And so there are a number of factors that can contribute to poor or little oral health and dental hygiene in this patient population. And then there are systemic illness and oral health impacts. I was just addressing with you the issue of bruxism, patients with cerebral palsy with spasticity and or bruxism, the development of erosion, enamel erosion from gastroesophageal reflux disease. Some syndromes such as Down syndrome have a rapidly progressive periodontal disease that can occur. A number of the adults with developmental disability have seizure disorders, and as you know, some of the older medications that we use for seizure disorder can be associated with gingival hypertrophy, and certainly in some of our more difficult to control patients with seizures, we end up using Dilantin and phenobarb for management of their seizures. And then some of us will use glycopyrrolate to control secretions, which impacts oral health as well. And this is just a picture of posterior enamel erosion. This can be the first indication for gastroesophageal reflux disease in some adults with developmental disability. In many instances, GERD is silent, or at least the adult with DD is unable to articulate their symptoms, and so your examination of the oral cavity or the dentist examination may pick up this posterior enamel erosion, which may be a clue that management of esophageal reflux needs to be instituted. I want to talk briefly about the pretreatment assessment in anticipation of visit to the dentist, and also just a little bit about the visit itself. Many instances it is very helpful if a clinical summary can be provided to the dentist or oral surgeon before the first visit, so that the providers of the oral care are aware of the specific issues that this adult might present with. And it is very important that the dentist has an opportunity to contact the person who can provide the most history, because you have to remember that the person who accompanies the adult with ED to their appointment may or may not be able to provide the necessary history, and they may not be able to provide consent for procedures to be performed. So you need to make certain that the legal guardian has been contacted and that the person who can provide the most information about the patient and their developmental disability is available or has been contacted before seeing the dentist. And then remember that sometimes, because of the contractures, the adult's inability to remain seated for a long period of time, agitation, that there may be may be required to have several shorter treatments over a long period of time than one prolonged visit with the dentist. And then again, think about all the needs for the treatment visit that might need to be modified. Will the dentist be able to communicate effectively with the adult with ED to accomplish the cleaning or whatever is being done? Do you have wheelchair, or does the dentist have wheelchair accessibility in their office? Certainly we would hope so, but can they accommodate the types of assist devices that some of our adults with ED use? Of course, the adjustment of the dental chair may be needed, and so these are things that the oral surgeon and or the dentist needs to be aware of. And then instead of medications, a calm environment, making sure that the dental hygienist and others are aware of the adult with ED who is coming that may be more easily agitated than others, and how to present themselves calmly. Certainly we try to avoid physical restraints, and pharmacologic sedation is not uncommon. Certainly some of the adults with DD we may give lorazepam or alprazolam to help calm the patient if they can cooperate for the examination. So things that are important to remember for oral hygiene. And then lastly, we want to talk about prevention. We need to understand that some of our adults with DD may not be able to use a toothbrush, and so there may need to be assistance provided to them in order to provide adequate cleaning of their teeth. And then we want to make sure that they're potentially using chlorhexidine as a mouthwash, fluoride to prevent cavities, and also sealants to help protect the teeth, and particularly when you are dealing with some enamel erosion and whatnot. So these are important things for us to remember, and again, we need to remember it as primary care physicians, because they may or may not, the adult with ED and the caregiver may or may not be able to access dental services, and so we want to do what we can to help provide them with better dental care. And so with that, I'm going to segue into medication review, which is one of the topics that we'll want to address. Now, this slide was not meant to be something that you can necessarily read, but it is to heighten your awareness of the adverse effects, the side effects, the drug-drug interactions that can occur with medications that adults with DD may be taking. And this looks at increased sun sensitivity. It looks at drugs that may contribute to obesity. It looks at drugs that may contribute to a long QT syndrome. And so, again, not so much that you want to memorize this list, but recognize that that there are a number of medication interactions and side effects from medications. And this is the reason that we want to make sure that we're reviewing with our adult with DD on a regular basis their medication list, including over-the-counter meds, to ensure that we aren't that they aren't taking medications that don't need to be on their med list. And so this is just kind of in your medication review, and I would anticipate that all of you as primary care physicians are doing this. We've already talked briefly about the fact that we don't want to use antipsychotic medications to treat behavioral issues unless there is an underlying psychiatric illness. We want to remember that tapering or discontinuing medications with no clear indication is important. You can always restart if symptoms return, but you can also taper. And remember also that there are the adverse effects of some of the atypical antipsychotics, the metabolic syndrome, prolonged QT, the drug-drug interactions, and certainly remember that if you are starting a medication that may prolong the QT, you want to do a baseline EKG before starting the medication, and then after the patient has been on the medication, bring them back in to repeat the EKG to determine that the QT interval has not been prolonged. And I don't know about most of you, but we are at least in the electronic world here, and so when we prescribe a medication for our patients, it aids us in providing warnings of drug-drug interactions and adverse effects, although I must admit that it's very easy to click right through all of those adverse events so that you can prescribe the medication, and it's something I have to slow down to do to make sure that I'm not overlooking a significant drug-drug interaction that may occur. And so medication review is critical, and that includes over-the-counter medications, as, again, those of us in primary care know that even our adults without developmental disability may be taking over-the-counter remedies that may be impacting their warfarin, may have an interaction with warfarin or other meds, and so it's very important. So from medication review, we're going to skip on to gastrointestinal disorders and nutrition. And I think that you can see the list of issues that can arise in the adult with developmental disability, and I think it's very important that we, again, do the review of systems to touch on these things and also determine whether there is a past history of any of these issues. And again, as we talked about last week, a change in behavior should trigger a search for possible GI issues such as constipation, GERD, or peptic ulcer disease. Same patient I saw this morning who has spastic quadriplegia had a Nissen fundoplication when he was a young boy. And so I think many of us who are managing adults with CP will know that a number of these individuals have already had a fundoplication as a child and thus have a history of gastroesophageal reflux that was very difficult to treat and warranted the fundoplication. Again, a lot of neuromuscular issues with regard to the patient with cerebral palsy. So don't forget, many times you'll see the scar, and the patient's or the patient's caregiver will provide you that history. Interesting, when you look at the prevalence, and you can see the prevalence is 9 to 80%. I think it depends on what patient population you are looking. There is autonomic dysfunction, gut dysmotility that contribute to GERD, undiagnosed GERD does contribute to misdiagnoses and can contribute to feeding problems and malnutrition. So again, important to ask the questions. They need to be monitored for Barrett's esophagus, and atypical symptoms such as aversion to food, poor or worsening sleep, or unexplained irritability or self-injurious behaviors may be a reflection of the GERD that is causing them problems. Now this is again from one of the references that I provided to you. It was a consensus report looking at autism spectrum disorder. However, I think that you can take this information and look at many of the adults with DD and see how these would be potential behaviors that might clue us in to looking for some gastrointestinal disorder that is contributing to the behavior. I won't review all these with you, but I think it is important. From whether it's grimacing or gritting of teeth or wincing, that these behaviors may clue us into evaluating for gastrointestinal disorder that may not be clinically evident to us. Again, this was something that I have learned over the course of working with Dr. Wood, and that is that for those patients who are with developmental disabilities that are institutionalized, we should be screening for Helicobacter pylori infection in the asymptomatic adult. Now, any adult who is symptomatic, we might want to consider screening, but certainly if they are institutionalized, they should be screened, and then every 5 years if they remain institutionalized. When there are symptoms of peptic ulcer disease, we don't want to forget other issues such as medications or mechanical trauma from G-tubes. We don't want to forget about acute hepatitis A, Epstein-Barr, CMV that can cause transaminitis. We want to be aware of these. And again, in the group home, there may be transmission of particularly hepatitis A, so we'd want to monitor for that. And then looking for chronic hepatitis with B and C. Remember now there's recommendations out there about screening for Hep C in the baby boomer age, and certainly some of our developmentally disabled adults are in that age group. And we've talked about the institutionalized setting. And then the celiac disease, again, if there are signs or symptoms that warrant evaluation, then we should pursue that. I think there in this article, in this consensus report, that does note that use of diets specific for celiac disease have not been proven to be effective in treating those with autism spectrum disorder. Feeding issues are very common. Again, we see this significantly in those with significant neuromuscular syndromes. NCP is one of the big ones. So it's important to monitor for cough or evidence of aspiration, and frequent video swallows should be performed to assess for dysmotility and whether or not feeding tubes may be warranted to prevent aspiration, or whether speech therapy should be called on to assist in helping to manage this. We've already talked about GERD and its impact on aversion to eating, so that's important. And then nutrition, we want to monitor the individual's BMI. Is their weight appropriate for their age? Are there significant vitamin deficiencies that they may have because of their diet, whether it be an enteral feeding or they eat orally? Then again, we've already talked about the higher functioning adult who may make less healthy food choices. And then there are the issues of feeding tube challenges, associated diarrhea, even weight gain associated with feeding tube challenges, because the caregivers think that if 3 or 4 cans of Ensure are good, then 8 or 9 may be good, and they don't realize the impact this may have on the weight of their young adult. And then, of course, with poor nutrition is a decreased immune system, and we've already got someone who may be aspirating, so this can be a challenge. Other GI issues, I didn't spend a great deal of time on constipation, but it can be particularly a major issue in adults with DD, particularly in the immobile patient. Again, diet contributes and medications contribute. We see this in the adult population without DD as well, but again, mainly because of the immobility and the diet. We see it in a greater number of our adults with DD. Celiac disease can be seen in Down syndrome. Remember that a number of our medications that we are prescribing for these patients are metabolized through the liver. So you want to do your quarterly med review to ensure that that if it is metabolized by the liver or if levels should be drawn, you are monitoring those and monitoring for drug-drug interaction. Interestingly enough, in patients who have seizure disorder, we need to be monitoring ammonia levels because certainly hyperammonemia can occur with Depakote and some of the other seizure meds, and that may necessitate tapering off those meds and using another anti-epileptic for their management. And then GI tract malignancies certainly are important to remember that they do occur in this patient population because of Barrett's esophagus and also other stomach malignancies as well. And this is just some takeaway messages from the consensus report. And again, the reference is provided for you. And again, we've touched on most of these, and I think I cannot say it any louder than I did last week as well. When a family member or a caretaker voices concern about the adult with ED, we need to heed that because they've been taking care of these adults for a while, and they, in many instances, recognize nuances that we may not. Bone health is very critical from scoliosis, which has been corrected with rods as younger individuals, to osteoporosis because of, again, immobility, meds, diet, to pain syndromes. And we don't want to forget about pain in the adult. And we need to remember that in many instances, the Harrington rods were placed when these were young people, young children. And so the screws that are there to stabilize the rods may come loose. There may be some pains associated with that. So critical to remember. From a standpoint of scoliosis, we want to remember that there is an impact on pulmonary function with scoliosis that can lead to sleep disordered breathing, and when you have greater than a 50% or greater curvature of the spine, certainly pulmonary function can be impacted. This also affects the individual's mobility, and it may change as they grow. So into an adulthood, you may still have some folks whose scoliosis worsens, and it is important to monitor for this. We've already spoken about pulmonary infections and how one of the leading causes of death in adults with DD is aspiration pneumonia, and certainly scoliosis can contribute to that. And it also contributes to pain. A number of our young adults will have already had surgical correction of their scoliosis, but we have had a few of adults who subsequently need to be seen by the orthopedic surgeon to determine if additional surgery is warranted. Osteoporosis is something that we see in the adult world frequently, but it was an eye-opener for me to see the number of young men and young women who have osteoporosis, who have particularly cerebral palsy, but other disorders that include seizures. And so certainly we know there's an increased incidence of osteoporosis in certain conditions, and cerebral palsy is one of them. But also remember that we have individuals who are on anti-epileptic drugs, which can contribute to osteoporosis. And also some of our women patients are on depo-progesterone, again, which can contribute to osteoporosis. As well, syndromes like Down syndrome, where there's associated thyroid disease, gonadal dysfunction, hypotonia, these things can also contribute to decreased physical activity and subsequently osteoporosis. So it's important to find out again about activity level, ask questions about unprecipitated fractures, and we monitor our patients for vitamin D to determine whether or not there may be a vitamin D deficiency that is contributing to their bone health as well. We are doing DEXA scans on this patient population, and then in some institutions are doing CT of the radius and using other biologic markers. How do you manage osteoporosis in a patient with cerebral palsy or an adult with developmental disability who has other comorbid conditions? Well, certainly you want to try and improve ambulation and mobility when possible. You want to check their vitamin D levels and supplement with calcium and vitamin D as appropriate. We refer our young adults, to endocrinology for their assistance in management and review their medications. Bisphosphonates can be used, certainly, but if you have a patient who already has severe gastroesophageal reflux, then the bisphosphonates may not be a good choice, at least orally, and also the adult's ability to sit upright after they've taken the medication can be a challenge. From a standpoint of pain management, again, I think the important thing to remember here is don't forget that these adults may have pain syndromes, and it is important to address them, involving physical medicine and rehabilitation physicians as appropriate, PT/OT. We make a lot of referrals to our physical therapist and occupational therapist to help improve pain in this patient population. And again, spasticity can contribute to pain, and remember there are medical issues that can increase spasticity, and so sometimes managing the spasticity may or may not address the pain syndrome. We have patients who are on baclofen pumps, patients that are receiving Botox, and so there are a lot of treatment options available to our patients through PM&R or orthopedic surgeons who can assist us. And then, of course, you want to make sure that as our adults with DD are growing older, that there's going to be the greater likelihood of developing osteoarthritis, and we want to manage that population as well. With regard to sexual health, this is often overlooked in the adult with DD, and again, depending on the severity of the DD, may or may not be an issue. Remember that in some of these individuals, they have had delayed puberty because of hypogonadal or hypogonadism, gonadal dysfunction. We need to address, as is appropriate with the adult with DD, fertility issues and whether or not the syndrome that has led to their developmental disability may be transmitted genetically to a child, and whether or not they want to have children. And then, of course, in those that are sexually active, the issue of sexually transmitted diseases, the role of Gardasil vaccination in both young men and young women, as well as cancer screening. So in women, you know, we do a fair amount of contraception in the adult with DD, but we have challenges with that. In many instances, we use the contraception for hygiene. It may be used for birth control, but certainly remember that there is the issue of weight gain associated with Depo-Provera, and also the issue of increase in venous thromboembolism in the patient who may already be sedentary. And again, a number of these patients may also be on seizure medications, and the seizure medication itself may decrease the efficacy of the oral contraceptive, and then if pregnancy occurs, there is the increased teratogenicity associated with some of the seizure meds. Certainly, the sexually transmitted diseases can be screened for using urine. Some of our young women are not physically able for us to actually do a pelvic exam, pap smear, because of spasticity and other issues. If they're not sexually active, annual exams and pap may not be warranted unless another symptom suggests such, or if there's a family history of a familial cancer syndrome. So these are things to remember when you're seeing a woman in your practice with DD. And then in men, don't forget about delayed puberty and the issue of hypogonadism. We've actually had a couple of patients who had low testosterone levels. They had decreased muscle mass, generalized weakness. However, when we began to treat them with testosterone, we had issues of agitation and aggression, and so you have to be careful in managing this patient population. And don't forget that we need to be screening these young men for testicular cancer. Certainly, some of the patients with some of the syndromes will have undescended testes, and so we need to be aware of this and manage them appropriate. And then we, as we do in the adults, we need to watch for or have the discussion with our men patients about prostate cancer screening and the appropriateness of it, and whether they want to be tested and whether there's a family history of prostate cancer. Epilepsy is is noted to have increased incidence in the adult population with DD, and the more severe the DD, the greater the likelihood that there's going to be a coexistent seizure disorder. And so here are some facts that we will help us in management of our patients. But remember that diagnosing seizures can be difficult in the adult with DD because of communication challenges, because of atypical presentations. We also need to be aware that when we manage their seizure disorder, that we can the treatment can affect the mood and the cognitive function of the adult as well. And we need to be aware of increased sensitivity to side effects of certain medications and the associated mortality that may occur. We have, I think all of you are familiar with the Lennox-Gastaut syndrome and with multiple seizure types. They have very poor long-term outcome, but be aware that a number of these patients will actually come to you with a vagus nerve stimulator. Be familiar with this and aware that some of the patients, even the adult with DD, may actually be taught to run the magnet across the VNS and change the firing of the frequency of the firing if they notice an aura or that a seizure is about to occur. So again, don't see this very often, but certainly there are a number of adults now with LGS, and it's important for us to be aware of them. Absolutely, neurology needs to be involved in management of this patient population. And it is important for us to talk to the caregivers about the history to help us better define what the seizure type might be. And remember that behavioral changes may be associated with subclinical seizures or may result from treatment which decreases seizures, or excuse me, but you may see some behavioral changes when you actually are decreasing the seizure frequency, but you're then changing the personality of the individual to either a more repressed individual, or they may become overactive. So again, important things to remember. And just we talked about Down syndrome last week, that there is an increased risk of developing seizures as an adult in the patient with Down syndrome, and usually this is linked to dementia. And so it is important for us to be aware of this as well. And lastly, I wanted to just touch on psychiatric illness and behavior issues, and we've touched on these as we've gone through the talk. But there are available psychiatric providers make it difficult for us. There aren't a lot of psychiatrists who are available for this patient population. Again, we have good working relationship with the psychiatry department here. Again, as I said earlier, the psychiatric illness itself may be overlooked because the presentation may be attributed to their underlying disorder. And we talked about the diagnostic overshadowing. So where at all possible, include your psychiatrist to help you in assessment of these patients. In general, mood, anxiety, and adjustment disorders are underdiagnosed, and we have a tendency to overdiagnose psychiatric disorders. And so before we go instituting psychotropics or antipsychotic meds, we want to make sure that our diagnosis is accurate, and that in many instances means having a behavioralist or a psychiatrist evaluate the patient first before instituting therapy. There are a number of studies that show that if there is a self-injurious behavior that is associated with a defined psychiatric illness, if you treat the underlying psychiatric illness, you can note a decrease in the injurious behavior that the adult is undertaking as an expression of their psychiatric illness. And then we don't want to forget there are adverse effects and side effects from hyperglycemia, metabolic syndrome, long QT syndrome that occur with management. And so we really need to be certain of the diagnosis when we institute therapy for psychiatric illness and behavioral issues. And then we don't want to forget about hearing, vision, and again, health promotion, disease prevention. I didn't talk about immunizations, but the adult immunization schedule should be followed. And it is important if there is on screening for hearing using the whispered screening test or his whispered voice test in the office, or the Snellen eye chart in your office. If there is anything that suggests either a vision or hearing problem, you need to refer them for screening. And then at the age of 45, adults with developmental disability should be referred for eye screening and for hearing screening to ensure that there are not any problems there that don't need to be addressed. So in conclusion, I think it's important that we incorporate wellness and preventive care visits into our management of the adult with developmental disability. We know that there are certain conditions that should be screened for in the DD population, and so we should make certain that we remember to do that. And then there's the screening for the general population that should also be followed in this patient population. And I can't emphasize more importantly how the involvement of specialists is warranted to assist in the management of many of these conditions, particularly our orthopedic, neurologic, and gastroenterology colleagues who can assist us in the management of these patients. And with that, I will stop.
All right. Thank you, Dr. Edwards. Thank you. Just on time, just in time. Well, I have a lot of information there. Let's see. I've got 3 comments before we even go into questions, but would you mind putting up the last slide there on the directions?
Yes.
For anybody who needs to run, and we're going to have a little time for questions here, but if you need to go, you can go to this link here, bit.ly.com/PEDD2012, and that will take you to our online system. There you can register and sign in if you haven't registered already. If you do register, you will get an automatic email confirmation. So just check your spam folder if you don't get one right away. Sometimes they'll end up in a spam folder somewhere. If you have any issues, as always, you can just go to www.aadmd.org and hit the contact button, and one of us can help you. On that site, you can complete the survey about this lecture. You can also take our quiz. Remember that 7 out of 10 is a passing score. And once you pass, you will the certificate will automatically be displayed and emailed to you so that you can print it out. Okay, so before I get to the questions here, I have a couple of comments. The first one, we did have some questions about the availability of the medication watch list that was presented. So if those of you who are still on, if you can check in your chat box, you should see a link from me, and you can. We're also putting that link up on our certificate website for anybody who's viewing the archived web version. But essentially, you can go to aadmd.org under the pharmacology tools header, and you can find that medication watch list and also a dental medication watch list as well that lists medications and their dental side effects. We had a dentist watching who wanted me to point out, just to clarify, that typically, and of course only a dentist would catch this, Dr. Edwards, but typically posterior enamel erosion in gastroesophageal reflux, although it was present in the slide that you showed, will be found in the mandibular teeth more prevalently than in the maxillary teeth. And I guess that's mainly because of how the head is positioned when reflux occurs. But they just wanted me to to make sure that I mention that to everybody. And also, I just had a personal comment about your comments about the psychiatric disorders and overdiagnosing them. You're spot on exactly, and I just wanted to let people know we're going to have a whole presentation about this issue from a psychiatrist, and his attitude is very much the same. I think you'll find most psychiatrists who have spent a lot of time treating this population agree with everything that you said. But it's certainly a worthy topic, and we'll be going into that later. Okay, so let's get to questions. First question that we had was about getting gynecological exams, and the question was, shouldn't women be getting, I guess this would be women with DD, getting gynecological exams because of the risk of sexual abuse in this population is so high?
Absolutely, I think if they're, and I think that is a difficult issue. We work with our gynecologist here, and they will do GYN exams under anesthesia. But as you might imagine, it is difficult to coordinate this, and so if you can coordinate lab draw, gynecologic exam, and other things together, that is helpful. Certainly, with the concern for sexual abuse, then absolutely that should warrant testing and asking our GYN colleagues or whomever to assist us in the management of this patient population. You know, many of the adults that I am seeing, and I would certainly defer to Dr. Holder, where you have more independent adults with DD, but the patients that we are seeing are very closely supervised and or living at home with parents, and I do ask the question of whether or not there is potential for abuse, either from someone who may be in the home or when they're off at school or whatnot. So I raise that question, but as far as the frequency and how to coordinate that, again, I haven't had a whole lot of experience with that, and probably should maybe ask Dr. Holder if he has any thoughts on that.
Well, it really is a difficult question. You know, the rates, at least the things that I've read about the rates of sexual abuse in this population, are very high, surprisingly high. And if we can believe those numbers, then I think it probably warrants. It certainly would, I guess, supersede any assumption that the person's not sexually active. So I think that for the most part, once our female patients reach a certain age, we like to examine them on a regular basis if it's possible, because that risk is always there. And also, you know, if you're thinking about a change of environment, sometimes you know, if they're in a very stable environment, and maybe it's not as likely, but then an environmental change, a caregiver change, all kinds of environmental changes could potentially increase that risk possibility. So, you know, it's one of those things that you may not even think that that there's a risk, but then you get in there and find something that could only have come through because of sexual contact, and now you're looking at potentially an abuse case, and so that those are always some things to keep an eye out for, I think. Let me ask another question. Actually, our dentist had another a question. I thought it was an interesting one. He said, "I'm a dentist, and I have problems with pre-medicating with benzodiazepines, that is. Can you comment on disinhibition in this population with regard to benzodiazepines?"
Actually, I have seen disinhibition with particularly adults with autism when we've used benzodiazepines. In most cases when I have used benzos, again, and if in many instances, they're going to require general anesthesia, or they are able to cooperate. But if benzos are required, usually the caregivers, parents, or whatnot have said, we have used this before and it has worked. And so I have gone with the parent or caregiver's recommendation. This is what we've used in the past. But I actually have had a couple of patients, and I think both were with have autism, who had the kind of hyperagitation associated with the benzodiazepines. I don't know, I'm not sure what other drugs might be used, pharmacotherapy might be used in this population for sedation.
Well, that's a good question. I think that's probably outside of my expertise on that one as well. I will say I know that our dentists have also had issues with that, with the disinhibition. I think autism is certainly high on the list there. I think there are probably others as well. But again, what you said, you listen to the families, and generally speaking, if you go back to the families and the caregivers, if they can tell you that it's worked, then it's a good thing. As far as what you can use in addition to that, stay tuned for perhaps another AADMD webinar. We'll have some dentists come and discuss that. Let's see. Another question. Oh, this was an interesting one. Any warnings about energy drinks? That was the question. And the issue being, I think that they had a case where the person had consumed way too many and ended up having almost like a manic kind of situation. Have you heard about this?
Gosh, there's certainly, those drinks are out there everywhere now. I would assume because they are stimulants, whether it be caffeine or whatever else might be in them, that it would be related to that. But I have not had any issues with the adults that I have seen with developmental disability drinking, or at least to my knowledge, drinking them. But again, I think it would likely be as you point out, the overstimulation and that might lead to a hypomanic or manic state.
Yeah, I know if I'm working on a paper or something and I have a Red Bull or two, nobody needs to cross my path at that point. So I imagine that works for anybody, for just about any patient of any type. So it's something just to watch out for sure. And I do know, in all seriousness, that a number of our patients are rewarded with soft drinks, and oftentimes these are highly caffeinated soft drinks. And they might be consuming 6, 7, 8, 9, 10 of these drinks a day, which is a lot of caffeine for any person, and certainly could lead to some behavioral issues. So if there's a question about that, just go back and look and see how much this person's consuming, and see if you can convince them to decrease.
Actually, I think that's a great question, and something that I probably don't inquire about, when a patient or their caregiver brings the patient in and says, they're more agitated, they seem to be more aggressive or more irritable. I must admit, I haven't thought to ask about questions of caffeine containing or chocolate or whatnot, and that certainly would be an appropriate question to ask.
Yeah.
So
it's a drug just like anything else, right? So,
yep, exactly.
Let me ask you another question here. This is a question about seizure disorders. Will seizure disorders increase as clients go into older adult status?
Now, again, I may have to defer to you. As far as I know, certainly in the adult with developmental disability, the more severe the DD, the greater likelihood of an associated seizure or seizure disorder. As far as I would anticipate that you have an adult who may have other risk that are things that may place them at risk, whether it be cerebrovascular disease from diabetes or atherosclerotic disease, that may potentiate the seizures. Again, I don't know that as an adult with DD ages in general, that makes their seizures more difficult to control.
Yeah, I think you're right. I don't think that age in particular is going to do anything, but as you mentioned, as we age, the propensity to have some kind of additional neurologic insult exists, and therefore could potentially increase your seizure risk. I wish we had Dr. Keller, who spoke earlier in the series, on the line tonight. He's a neurologist, but I think that in Down syndrome, I believe that as those patients age and of course become at risk of having Alzheimer's dementia, that there is an increased risk of seizures as they get older as well. But I think it's probably more organic than just specifically age-related. So I don't think just because somebody has DD and they're getting older, they're guaranteed to get more seizures. But maybe in the population, you might see that as a result. But you probably see that in the population of everybody in reality. And let's see, another question. What do you think about diagnoses such as intermittent explosive disorder and the use of medications to help individuals with highly impulsive behaviors?
Well, we actually have a couple of young adults that have been diagnosed with this. Again, it was a diagnosis that was made by our psychiatrist and then managed. So, I mean, I think that there are certainly adults with DD have inhibitions and difficulty in controlling their behavior. And again, asking a psychiatrist to help us discern whether this is an impulse control disorder or whether this is a behavior that needs to be modified is where we rely on the psychiatrist to help us with that. Because I don't want to, again, I don't want to label someone with a psychiatric disorder when it indeed is just a behavior that is either a reflection of a change in their status at home or wherever they are living or at school, instead of giving them a psychiatric disorder.
Well, and we'll be able to ask that question for those who are going to tune into Dr. Steve Rudrick's talk later on in the series. We'll be able to ask that question of him as well. Dr. Edwards, I'd really like to thank you for your presentation tonight.
Thank you.
And thank all of you for attending. Please remember that if you want to get your CME certificate, just go to the link that we have on the website. If you have any questions or concerns, you can email me at mattholder@aadmd.org. Please join us next Tuesday at 6 p.m. Eastern Time for our presentation on optimizing well-being. See you then, and thank you from all of us at the AADMD, and have a good night.